Good evening, everyone. I thank the organizers, Dr. Smriti, Dr. Jyoti, for this kind invitation. It's an excellent opportunity to be with you all, and it's a great honor. The plethora of drugs that are available for systemic therapy options for metastatic RCC has virtually exploded over the past few years. We are already aware of the VEGF TKIs and the mTOR inhibitors and the immunotherapy. Now, the exciting new thing is that newer classes of agents are being added in 2021 and 2022. How do we select treatment for metastatic RCC in different patient populations? We have had different ideas. We have put them into use. We select based on whether they are indolent or whether they are fastly progressing. We risk stratify them as good risk and intermediate and poor risk. And then based on whether they are clear cell or non-clear cell, and with their aggressive behavior and whether they have hereditary disease, so on and so forth, and whether they have been treated in the first line and if so, with what. But we have always been accustomed to using the prognostic classifications in stratifying the treatment options ever since the MSKCC. The IMDC is also a very, very useful and practical risk model with very repeatable risk factors like Kornofsky's performance status, hemoglobin, calcium, so on and so forth. But what is important is the score of 0 is the favorable risk, and intermediate risk is 1 to 2, and poor risk is more than 3. So more than 75 to 80% of the patients who are all candidates for first-line treatment for metastatic RCC seem to have at least one of these risk factors and therefore would qualify as intermediate and poor risk. We know that these IMDC risk factors are clearly prognostic for overall survival itself. 2015, the treatment choices were very simple. There were the TKIs, sunitinib and pazopanib, followed by mTOR inhibitors, everolimus, and then whatever was left. That's all we had. In 2017, we had the introduction of immune checkpoint inhibitors, nivolumab, and then post the TKIs, we considered immune checkpoint inhibitors as the second choice. And then we started trying combinations. And things have started to change rapidly. In early 2021, if you look at the possible options as categorized by the NCCN guidelines for first-line therapy with clear cell histology, axitinib plus pembrolizumab and pazopanib and sunitinib were considered as the preferred regimen. And ipilimumab and nivolumab and axitinib and pembrolizumab were considered as preferred regimen for poor and intermediate risk. Pazopanib and sunitinib was the most common and probably is still the most common drugs that are used in this setting. And cabozantinib made an advent, and cabozantinib became important for poor and intermediate risk and also for second-line therapy. But in the late 2021, we saw the introduction of combinations. Along with axitinib, pembrolizumab, we had the cabozantinib and nivolumab, lenvatinib and pembrolizumab added to the preferred regimen for favorable risk factors and for poor and intermediate risk factors. And in the subsequent line, nivolumab as a single agent and EP plus nivo as a combination made their impact here. But if you look at the 2022, what has happened is the pazopanib and sunitinib has been moved away from the first-line preferred regimen to other recommended regimens. And lenvatinib and everolimus is added to the second-line armamentarium. And nivolumab single agent has also been category 1 for second-line therapy. So if you look at the preferred regimens in the first line for favorable histology and for poor and intermediate risk groups, you see that the combos have category 1 recommendation: axitinib plus pembrolizumab, cabozantinib plus nivolumab, lenvatinib plus pembrolizumab for both favorable risk factors and for poor and intermediate risk factors. And we now see that the nivolumab plus ipilimumab combo has been moved out of the subsequent regimen into the other recommended regimen, and nivolumab as a single agent has gained the category 1 recommendation. But how do we really select these agents in our real patients in front of us? We need to look at some of the takeaways from these trials and try and decide. If these are the important numbers, for single agent sunitinib and pazopanib, the median progression-free survival is around 8 to 9 months, and the median overall survival is around 29 months. And for the intermediate and poor risk group, we have the cabozantinib median PFS is 8.2 months, and the overall survival is 26 months. If you look at the combinations, the important studies that have established the combinations are listed here, and all of them have an overall response rate of anywhere from 50 to 70% for the combinations of immune checkpoint inhibitors and the TKI. The Ipi-Nivo combination has got a response rate of 39%. But if you look at the complete response rate, the Ipi-Nivo has got 11%, and lenvatinib plus pembrolizumab has got 16%. These two have scored double-digit or complete response rate. If you look at the median overall survival, at least the 24 months landmark overall survival is available for lenvatinib and pembrolizumab, axitinib and pembrolizumab, and the Ipi-Nivo, and they all have scored 70% overall survival at the landmark of 24 months. And now the PFS and the safety of all these combinations are well established, and most of the clinicians are very familiar with these combinations now. But if you look at the cross-trial comparisons, that will help us at times to choose the patients for the patients in front of us. If you look at the overall response rate for all the combinations with VEGF inhibitors and the immune checkpoint, they all have an overall response rate of anywhere between 50 to 70%, as I mentioned. And Nivo-Ipi has got an overall response rate of 39%. But if you look at the progressive disease, an early progressive, Nivo-Ipi has got an 18% progressive disease, and the combos with VEGF, TKI, and immune checkpoint inhibitors have got a low progressive disease. And if you look at the overall survival, the 24-month landmark overall survival, all of these combinations have scored more than 70% landmark overall survival at 24 months. So we also look at the curves of some of these important trials and try to take away some important inference. If you look at the Checkmate 214 Nivo-Ipi combo, you see that these curves separate very late at 9 months. So that is the segment where there are early progresses. Whereas if you combine the TKIs with the immune checkpoint inhibitors, you see an early separation of this curve. That's an important takeaway for us. But if you follow these two trials, Checkmate 214 and Keynote 426, you have other important takeaways that at 30 months, if you see the Ipi-Nivo combination have started to show a flattening of the curve. And if you look at around 42 months, you have a 35% of patients in the Ipi-Nivo combination still are progression free, and these patients are potentially long-term survivors and are probably cured. And if you also look at the achievement of complete responses in these two important trials, you see that people who achieve complete response have a very good durable complete response, and both in the Ipi-Nivo trial and also in the axitinib pembrolizumab trial, you see that this complete response converts into an overall survival. If you look at the New Age trial, like the combination of cabozantinib with nivolumab, the Checkmate 9ER, you see the same concept that they have a very impressive progression-free survival with a hazard ratio of 0.51 and a very impressive overall survival. The overall survival is not yet reached, and the hazard ratio of 0.6. So these combinations have clearly established both the PFS and OS advantage. And the Checkmate 214 and the Keynote 426 and the Checkmate 9ER, these combos have clearly shown overall survival benefit, and they have all been FDA approved. The other combinations like avelumab and axitinib and atezolizumab, bevacizumab and pembrolizumab have all shown PFS benefit, but has not yet demonstrated overall survival benefit and are pending approval. Once these patients are on these first lines and they progress, how do we choose regimens for progressive disease? It was very easier 5 years ago. There were only VEGF TKIs and mTOR inhibitors. Now the sequencing has become more and more complicated with the advent of all these available agents, and number of phase 3 trials and phase 2 trials are listed here. The most important one are the axitinib, everolimus, and cabozantinib in the phase 3 trial, and Checkmate 025 for nivolumab phase 3, and the lenvatinib plus everolimus phase 2 trial in the second line. If you look at the lenvatinib and everolimus, you see an overall response rate of 35%. All the other single agents have shown 20% response rate, and you also see an impressive PFS and overall survival advantage with lenvatinib plus everolimus in the second line. And particularly if you have patients who are rapidly progressing, you see that cabozantinib and lenvatinib plus everolimus do well, whereas nivolumab is not able to do well in that particular setting where there is a rapid progression. So these are the factors you consider when you try and choose your regimen. If you have patients who are on first line TKIs and then they progress, you ask this question. I mean, what do I do? Do I look at response rate, overall survival, PFS? Has there been an approval? You look at all these factors and make your decision. So the second line priority list are cabozantinib, nivolumab, lenvatinib, everolimus, and axitinib until we have biomarkers. But if you had put this patient on already combination, then on progression, you can consider either nivo-ipi or cabozantinib. And if you have put the patient on nivo-ipi, you have cabozantinib in second line. But if you had put the patient on cabozantinib combination in the first line, then on progression, you can consider lenvatinib plus everolimus or nivo-ipi as your second choice. Other interesting trials to point out here are that nivolumab induction and post progression, you give a boost of rescue with combos like nivo-ipi doublet as a rescue for patients who progress on single agent nivolumab. And the checkmate 016 is something to be pointed out in the second line nivo-ipi combination as a rescue, as a doublet. There are some newer ideas in the treatment of metastatic RCC. Here we have the atezolizumab plus cabozantinib. These are dose findings, phase 1, phase 2 trials, but they have very impressive waterfall plots for both 40 milligram cabozantinib and 60 milligram cabozantinib, even with sarcomatoid variants. And this is cabozantinib plus atezolizumab, Cosmic 021 trial, phase 2 trial of this combination. And we are waiting the results of this. And the other important trial to point out is the phase 3 trial of atezolizumab plus cabozantinib and Contact 03, and this has completed enrollment and we'll wait for these results. Another important class of agents are the HIF2 alpha inhibitors, hypoxia-induced factor 2 alpha inhibitor, belzutifan, and it's also known as MK6482, and it's undergoing rigorous trials. And this is phase 1 and 2 study of belzutifan, and that shows an overall response rate of 25% in all patients, and even in a poor risk group, you have a 24% response rate, and you have more than 64% of the patients showing useful target lesion reduction, and waterfall plots are very impressive, and these are in second line setting. So these are very important group of agents that are emerging, and they also have not only an impressive response rate, but they have also a very good durability of these responses. And the PFS for belzutifan is 14 months in the second line setting. So this will definitely become an important drug in the future. And this is the combination of belzutifan plus cabozantinib. And this is a phase 2 trial, multicenter to cohort trial. And what are the practical challenges in the treatment of metastatic RCC? All these agents are available, but there is always the issue of cost and the patient's performance status, their ability to tolerate. So if you see that there's a significant attrition of these patients from first line, when you move on to second line, only 50% of the patients ever get exposed to second line. And then when you come to third line, it decreases further, less than 25%. So cost is an issue. We need to consider this. And the patients become fatigued when you go on to take them from first line to second line, and their performance status and tolerability issues also come into picture. The other important issue is that you have multiple groups or multiple agencies having recommendations on how do you proceed with your first line and second line. You have NCCN, you have the European group, you have so on and so forth. But if you look for consensus, it's going to be elusive. So you're going to be on your own most of the time, even in first line, because your patient is going to be unique with their own risk profile and their own general condition and performance status and their own economic status. So mostly you are on your own when you select this in the first line and second line. That has to be considered. So no 2-3 teams or no 2-3 doctors are going to choose the same thing in most of the time. There may be some commonalities, but you have to respect that there can be some differences. We have also not covered issues like active surveillance, cytoreductive refractomies, And how do you choose non-clear cell RCC treatment, sarcomatoid variant, and when there is a hereditary RCC, so on and so forth. Lastly, there is something called patient wisdom. You may have all these wonderful info in front of you, and you may talk to the patient on evidence-based medicine or holistic medicine or personalized medicine, but the patient will finally choose what he or she wants to choose. Convenience always comes into picture, and the patient will say that I will choose what I want to choose. That's how most of the time happens in the clinic. So have your eye on the patient in front of you when you want to plan your treatment, first line and sequence. So with that, I sincerely thank you for your time and attention. And once again, thank the organizers for this wonderful opportunity. Thank you so much.